Usually when we talk about a medical diagnosis, there's this expectation of precision. It feels very mechanical, you know?
Right, yeah, like it's a binary thing.
Exactly. You break your arm, the x-ray shows that jagged white line, and the clinician just points and says, there it is. It's either broken or not broken.
And we crave that. We inherently want that visible, categorical certainty in medicine.
But if you step into the world of neurology, and specifically what we're looking at today, the mechanics of seizures, that x-ray machine is completely broken.
Oh, completely. It's an entirely murky diagnostic landscape.
It really is. So welcome to today's deep dive. We've got a fascinating stack of nursing and clinical sources today, and our mission is to unpack the exact mechanics of seizures. We want to explore the critical differences between seizure types and, most importantly for you listening, equip you with the exact evidence-based safety steps to take at the bedside or even just in daily life if a seizure happens.
Because there is this massive and honestly often dangerous gap between what the brain is actually doing electrically and what the body is showing you visually.
Yeah, and that tension is wild. Okay, let's unpack this because to manage a seizure, you have to look past the physical shaking, right?
Yeah.
How has our fundamental understanding of this shifted? Because this goes way back.
It does. I mean, the biological understanding is much older than most people realize. If you go all the way back to roughly 400 BCE, you find this Hippocratic text called On the Sacred Disease.
Which is a very dramatic title.
Right, but the author was remarkably ahead of their time. They were aggressively pushing back against the dominant Greek idea that epilepsy was, a demonic possession or some divine punishment.
Wow, so even back then they were saying, no, this is biological.
Yes. They explicitly argued it was a disease of the brain. They basically said blaming the gods was just a convenient cover for medical ignorance.
That's incredibly modern for 400 BCE.
It is, but unfortunately it didn't stick. That whole supernatural or viralistic framing hung around for over 2 millennia.
Jeez.
Yeah. Even into the Victorian era, doctors were treating epilepsy as this uniform disease caused by, and this is a quote, moral degeneracy.
Yikes. So when did we actually get the modern medical definition?
Not until the late 19th century. In 1873, a British neurologist named John Hewlings Jackson finally completely redefined it.
And what was his definition?
He called a seizure an occasional, an excessive, and a disorderly discharge of nerve tissue.
Huh. Disorderly discharge. That's a great phrase.
It's perfect, really.
Yeah.
He basically decoupled the physical convulsion from the disease. He said, look, a seizure is merely a symptom. It's just a final common pathway for these abnormal electrical discharges. And they could originate anywhere in the brain for, countless reasons.
Which I guess introduces a huge distinction that we need to make right now, the line between a seizure and epilepsy.
Right, because they are absolutely not the same thing.
For a long time, the clinical practice treated those terms interchangeably, right? Or you needed to have, 2 unprovoked seizures to be diagnosed with epilepsy?
Yeah, that was the old rule.
Huh.
But the International League Against Epilepsy, the ILE, they drew a much harder line, first in 2005 and then practically in 2014.
Okay, so what's the new line?
Basically, a seizure is a single transient event. It's just a momentary electrical storm. Epilepsy, on the other hand, is the enduring disease. It's the brain's baseline predisposition to keep generating those storms.
Wait, so let me clarify this for you listening. A person could have a dramatic full-body convulsion, a seizure, and not have epilepsy.
Absolutely. You can have a single provoked seizure from a high fever or severe alcohol withdrawal or a traumatic head injury. That does not equal epilepsy.
Because it was provoked by an outside factor.
Exactly. Once the fever or withdrawal is resolved, the risk goes away. But, and this is the 2014 shift, you can now be diagnosed with epilepsy after just one single unprovoked seizure.
Wait, I want to challenge that. Diagnosing a lifelong neurological disease after just one event, that feels incredibly aggressive.
It sounds aggressive, yeah.
Because, if someone has one seizure, slapping them with an epilepsy label means immediate driver's license suspensions and starting them on these heavy, long-term anti-seizure medications. Why make that leap after one isolated event?
Because of the underlying structural data we can get now, the rule is you can diagnose it after one unprovoked seizure if your risk of having another one is 60% or higher.
Oh, I see. So how do we know the risk is that high?
Well, say a patient comes in after one seizure, and we do an MRI, and it reveals a distinct structural brain lesion, like cortical dysplasia or damage from a past stroke.
So the hardware is visibly damaged.
Right. In that case, the risk of recurrence isn't just theoretical, it's anatomically highly probable. That 60% threshold actually mirrors the exact same recurrence risk we see in people who have had two unprovoked seizures.
Okay, that makes sense. You don't want to just wait around for a second seizure to happen if you already know it's coming.
Exactly. It dictates when we can start neuroprotective treatments without waiting for another potentially devastating clinical event.
Got it. Okay, so we're defining a seizure as this transient electrical discharge. Let's talk about the actual mechanism. Why does a cluster of neurons suddenly just short circuit and go into this hypersynchronized sprint?
It all comes down to a catastrophic failure of balance. Neuronal communication relies on a very delicate equilibrium between excitatory neurotransmitters and inhibitory ones.
Excitatory and inhibitory, okay.
Right. So glutamate is your main excitatory neurotransmitter. It opens sodium and calcium channels, which depolarizes the neuron, pushing it closer to firing.
So glutamate is the gas pedal.
Perfect analogy, yes.
Yeah.
Glutamate is the gas pedal. Then you have GABA, which is your primary inhibitory neurotransmitter. It opens chloride channels, acting as the brakes.
So what happens during the seizure?
Either the inhibition completely fails, or the excitation just wildly overwhelms the system. The brakes give out, the gas pedal gets stuck, and a localized group of neurons breaches their threshold all at the exact same time. They discharge in this massive, synchronized wave.
Wow. And what that wave looks like from the outside depends entirely on where it starts in the brain, right?
Exactly. The semiology, or the outward appearance, is all about location.
Let's look at some concrete examples from the sources because this is wild. If we look at the classic Jacksonian march, which is a focal motor seizure, you can literally watch the electrical spread happen in real time.
It's one of the most remarkable things to witness clinically.
Yeah, it starts with like a twitch in a patient's thumb, and then over a minute, that twitch physically marches up their wrist, into the forearm, up the shoulder, and finally to the face.
What you're seeing there is the electrical storm tracing the exact physical map of the motor homunculus in the brain.
The homunculus being that map of the body on the brain's surface.
Right. The discharge starts in the tiny cortical area that controls the thumb, and as it spreads across the adjacent brain tissue, the physical twitching moves up the arm. The clinical symptom is a perfect real-time mirror of the brain's electrical spread.
But it doesn't always involve movement, which brings up a huge diagnostic challenge. Like with absence seizures, we see this a lot in kids.
Yes, pediatric absence seizures are very common and very misunderstood.
A 7-year-old might be talking, suddenly stop mid-sentence, stare totally blankly for like 8 seconds, and then just finish their sentence like nothing happened.
No confusion afterward, no memory of the pause whatsoever.
Right. And you noted from the sources this gets constantly misdiagnosed by teachers as ADHD, right? Just a kid zoning out.
All the time. Because there's no overt convulsion. It's a generalized onset seizure, driven by this highly synchronized 3 per second spike and wave discharge across the brain.
3 per second, wow.
Yeah, the thalamus and the cortex get locked in this rapid firing loop. It disrupts consciousness entirely, but since it doesn't hijack the primary motor pathways, they just freeze.
That is so wild. But then you have an even more invisible seizure, the ecstatic aura. And the most famous example from the text is the Russian novelist Fyodor Dostoevsky.
Ah, yes. A classic case study in temporal lobe epilepsy.
He literally experienced this wave of transcendent joy, like an intense feeling of hyperreality right before his convulsions would start. He even wrote this euphoric feeling into characters in his novels. But like, I get how a misfire in the motor cortex makes a thumb twitch. How does a short circuit create, like, synthetic joy?
What's fascinating here is the specific anatomy of the temporal lobe. It has incredibly deep connections to the limbic system.
The limbic system, that's where emotions live, right?
Exactly. The amygdala, the hippocampus, these structures are fundamentally responsible for processing emotion, forming memories, and assigning meaning to things. So when a seizure originates there, it electrically hijacks the brain's reward centers.
So it's just artificially flooding the system with profound meaning.
Yes. But here is the most crucial nursing takeaway. That aura, that feeling of joy or a strange smell or intense déjà vu is not a warning sign before the seizure.
Wait, it's not a warning.
No. The aura is the seizure. It is a focal aware seizure. If a patient reports an overwhelming, unexplainable metallic taste, they are actively having a cortical discharge right then, even if they're sitting perfectly still.
Okay, that blows my mind. The aura is the seizure itself.
Yes, and this introduces a massive clinical trap. You absolutely cannot trust your eyes. The tension between the electrophysiological event, what the brain is doing, and the behavioral event, what the body is doing, is huge.
Because they can be completely out of sync.
Right. Picture a heavily sedated, mechanically ventilated patient in the ICU. Behaviorally, they are perfectly still. But if you hook up an EEG, you might see massive, continuous electrical discharges.
So their brain is violently seizing, but their body isn't moving because of the sedatives.
Exactly. It's called non-convulsive status epilepticus. And if you don't catch it on the EEG, the brain is sustaining permanent metabolic damage while the nurse thinks they're just resting peacefully.
Wow. And then we have the exact inverse of that, which I think is even more shocking. Psychogenic non-teleptic seizures, or PNES.
Yes, PNES. This is a massive issue.
A patient can be lying in a hospital bed having violent full-body convulsions thrashing around, arched back. But the video EEG shows totally normal brainwaves, no electrical storm at all. And the stats on this are crazy. 20 to 30% of patients sent to specialists for drug-resistant epilepsy actually have PNES.
It's staggering. And the clinical danger is that because it looks exactly like an epileptic seizure, these patients get put on massive doses of heavy anti-seizure medications.
Which have terrible side effects.
Severe neurocognitive side effects, systemic issues, and the drugs do absolutely nothing to help because the problem isn't an electrical short circuit in the cortex.
I mean, this feels tricky to talk about. If the EEG is totally clear, how is it a seizure? Isn't this just someone faking it or like a panic attack?
That's a really common misconception, but no, they're absolutely not faking it. It's a functional neurological disorder. It's a real psychological and neurological condition.
So what's actually happening if it's not an electrical storm?
The central nervous system is genuinely generating involuntary motor output. It's often a deeply ingrained protective mechanism triggered by severe past psychological trauma or extreme stress.
Like a software glitch rather than a hardware short circuit.
That is the perfect way to phrase it, a software malfunction.
Mm-hmm.
The subjective experience of losing control of their body is 100% real to the patient, which is why video EEG monitoring is the absolute gold standard to tell them apart, so we stop pumping them full of the wrong drugs.
Okay, so if PNES shows we can't trust our eyes, the famous Pokemon incident from 1997 shows we can't trust our assumptions about seizure triggers either.
Oh, the Didn't Senshi Porygon episode.
Yeah. Over 600 kids in Japan had seizures at the exact same time during that broadcast because of this sequence of flashing red and blue lights.
Oh.
How does a cartoon actually hijack the brain?
It's a phenomena called photic driving. When you see a really intense, rapidly alternating visual stimulus, the neurons in the back of your brain, your visual cortex, try to synchronize their firing to match that flashing frequency.
Okay, so the brain matches the strobe light.
Right. In a normal brain, that stays contained. But in a patient with photosensitivity, that synchronized rhythm acts like a pacemaker. It overwhelms the local inhibition, spreads across the entire cortex, and triggers a generalized seizure.
That one broadcast literally changed global animation standards forever.
Yeah.
But it also created this huge myth, right? Like, the public assumes flashing lights are a danger to everyone with epilepsy.
It's a huge misconception. Photosensitivity is remarkably rare. It only affects about 3 to 5% of people with epilepsy.
Only 3 to 5%? Wow.
Yeah, it's highly specific, but it completely dominates how the public thinks about seizures.
Well, here's where it gets really interesting, because that kind of cultural myth bleeds right into bedside nursing and how we physically respond. We really need to bust some dangerous first aid myths.
Absolutely. The historical first aid practices are honestly terrifying.
Like the whole swallowing the tongue thing. For decades, the instinct was to force a spoon or a wallet or a bite block into someone's mouth while they were convulsing.
Which you should absolutely never do. It's anatomically nonsensical.
Because your tongue is attached at the base, right? You literally cannot swallow it.
You cannot. And when a patient is having a generalized motor seizure, their jaw muscles contract with immense crushing force.
So if you stick a wooden spoon in there,
you're going to cause shattered teeth, severe lacerations to the gums, and now the patient has broken fragments in their mouth that they can choke on. Not to mention the rescuer is going to get their fingers bitten to the bone.
Just terrible all around. And what about holding them down, restraining their arms?
Another terrible idea. Pinning a convulsing patient down does absolutely nothing to stop the electrical storm in their brain.
Right, the brain's still seizing regardless.
Exactly. All you're doing is creating opposing mechanical forces. The muscles are contracting violently, and if you hold the limb still, it frequently leads to joint dislocations or even bone fractures.
So what is the actual correct bedside action?
The standard nursing best practice is very clear. You clear the area of sharp objects, cushion their head, and turn them onto their side, the recovery position.
To let any saliva or fluids drain out instead of choking on them.
Yes. And most importantly, You time the event.
Timing is everything. But quickly, before we talk about why the clock matters so much, we should mention the mimics that happen right after a seizure, like Todd's paralysis.
Oh, Todd's paralysis is a huge diagnostic curveball for triage nurses.
Yeah, a patient comes out of a focal motor seizure and they have complete flaccid paralysis on one side of their body. It looks exactly like they just had a massive stroke.
Right, but it's not a stroke. The mechanism is essentially severe neuronal exhaustion.
The brain cells are just tired.
Profoundly tired. After that massive electrical sprint, the neurons have depleted all their energy reserves. They are unresponsive to normal signals while they try to reestablish their baseline balance.
And so that part of the body just physically shuts down temporarily.
Exactly. It can last for minutes or even hours before function returns.
That's terrifying for bystanders. Okay, but let's get back to the clock. Why is timing the seizure the single most important intervention? It has to do with a life-threatening emergency called status epilepticus, right?
Yes, and this is where the definition of a medical emergency has radically changed.
Because historically, a seizure had to last for 30 straight minutes before it was officially called status epilepticus. But in the 1990s, heavily influenced by Dr. Daniel Lowenstein, that got slashed down to just 5 minutes. Or 2 seizures without waking up in between. Why the huge change?
The old 30-minute rule was based on when we could physically see irreversible cell death in the brain. But pharmacologically, the danger starts much earlier.
How so?
It's all about receptor trafficking. Remember GABA, the
Or
brakes.
the inhibitory receptors.
When a seizure hits the 5-minute mark, this terrifying thing called receptor internalization happens. The constant electrical bombardment actually causes the GABA receptors to physically pull back and retreat inside the cell.
They literally hide inside the cell.
They do. They downregulate into the cytoplasm. And at the exact same time, excitatory receptors move to the surface.
Oh, wow. So it's a double whammy.
Yes. And this creates a catastrophic problem for treatment. Our primary rescue drugs, like lorazepam or other benzos, work by binding to those GABA receptors to hit the brakes.
But if the receptors have retreated inside the cell,
The lorazepam has absolutely nothing to bind to.
Yeah.
The drug becomes useless, the seizure becomes self-sustaining and increasingly resistant to medication with every single passing minute.
wow. So the core nursing mantra, time is brain, is literally about catching it before the brakes disappear.
Exactly. Every minute of delay shrinks that treatment window.
That is profound. So pulling all of this together for you listening, why does this matter to you? The sources point out that roughly 1 in 10 people will have a seizure in their lifetime. That's a lot.
It's incredibly common.
Whether it's a kid having a febrile seizure from a fever, someone reacting to really low blood sugar, or true epilepsy, knowing how to recognize it, knowing what not to do, no stoons in the mouth, and keeping them safe on their side while timing it means you can actually protect them from harm.
It's empowering knowledge, truly. And I'll leave you with one final thought to mull over, especially regarding how invisible these things can be.
Yeah, hit us.
If an aura is completely subjective, and a seizure can be entirely invisible to the naked eye like in the ICU, think about what the future of wearable tech might look like.
Oh, like a smartwatch for your brain.
Exactly. If we eventually have continuous, non-invasive EEG mapping in our daily lives, we wouldn't just be reacting to a seizure after it starts. We could predict the electrical shift in the baseline phase, hours before the storm even gathers. We could stop it before those GABA receptors ever fail.
That is an incredible thought to end on. From demons to smartwatches, what a journey. Thank you so much for joining us on this deep dive into the mind and body. We'll catch you next time.